and get started here now. Good evening, everyone. Thank you so much for joining us for our monthly webinar. I know I see a lot of familiar faces on the list, so thank you for joining us again. As you know, we host these monthly, and they cover all things sleep and TMJ, as well as practice growth in these areas. So if there's ever a specific topic you want us to cover, feel free to drop that in the chat box, and we will address that. Like I mentioned, your camera is off and you're muted for the webinar. The best way to view the webinar is in speaker view. So the upper right-hand corner of your screen, there'll be a view option and you can select speaker view. That'll give you a nice side-by-side of Dr. Patel and the PowerPoint. If you do have questions throughout the webinar, feel free to raise your hand and I can unmute you or utilize that question and answer chat box and we can get those addressed to Dr. Patel. Our webinar topic today is sleep apnea and TMJ disorders and what's the deal. So feel free to ask those questions and live attendees will be receiving a promo code at the end for additional training with Dr. Patel. So make sure to stick around for that. I'll pass it over to Frank now to share a little bit about True Function for those new faces on here.
Wonderful. Thank you, Trish. Well, I want to start by thanking Dr. Patel for joining us again. We really appreciate you sharing your all your knowledge and expertise with us and the group joining us. So thank you. We are blessed to have you. A little bit about True Function. We started this thing in 1999. So it's been 25 years now. We're 25 years into this. And this is an amazing time at True Function. We are, going through so many changes and growth and evolution. And I'm like overwhelmed with excitement. So we got a few things coming. We got, pretty much a full digital service coming probably sometime next year. We got new products coming, very excited about. We're not quite ready to share them yet, but they are on their way. And the thing that's most exciting to me is really, the team that I work with, amazing people like Trish and everyone back at True Function that take care of us and take care of you and your patients. So what makes True Function different is it's really our intention. It's how we do what we do. Our number one thing that we focus on is your patient's well-being, how we can make that device better, fit better. You'll get communication if we have any questions or concerns about the case. So there's a lot of communication from our end. And of course, your peace of mind, making sure, again, with our communication and our quality products and our processes, constant improvement, that we're taking care of you. Our goal is to make you look good. And, once in a while, things will go a little bit south with the case for whatever reason. We are very responsive. So, we're completely open to communication, open to learning more along with you. And for those of you that need a little bit more guidance, open to supporting you in that, in your knowledge and in your growth of your practice. So again, welcome. Thank you for joining us. We appreciate you. And Dr. Patel, again, thank you for what you do.
No problem. Thanks, Frank. Thanks for having us, and Trish. Thanks for making sure that we're on par and have these awesome webinars to share with your clients and all the dentists that are interested in this space.
Of course, yeah. And we also need to throw a shout out to Tara too, because she's the one that kind of does everything on the back end and really keeps things organized. So hopefully she sees the recording of this.
If they don't know who you guys are both TNT, remember?
Right. We're just one person combined. Well, I would like to introduce our clinical director here at True Function and a dear friend of ours, Dr. Mayoor Patel. Dr. Patel received his dental degree from the University of Tennessee in 1994. After graduation, he completed a one-year residency in advanced education in general dentistry. In 2011, he completed a Master's of Science from Tufts University in the area of craniofacial pain and dental sleep medicine. Dr. Patel has earned his fellowship in the American Academy of Oral Facial Pain, American Academy of Craniofacial Pain, the International College of Craniomandibular Orthopedics, the Academy of General Dentistry, and the Prairie-Fachard Academy. He also has earned his diplomat in the American Board of Dental Sleep Medicine, the American Board of Oral Facial Pain, the American Board of Craniofacial Pain, and the American Board of Craniofacial Dental Sleep Medicine. Presently, Dr. Patel is the co-founder of the British Academy of Dental Sleep Medicine and the BenPat Institute. He also serves in the American Academy of Craniofacial Pain as a secretary, the board member of the British Society of Dental Sleep Medicine, and a board member as the examining chair of the American Board of Craniofacial Pain and Craniofacial Pain Dental Sleep Medicine. In the past, he served as the founding board of the Georgia Association of Sleep Professionals. Since 2003, Dr. Patel has limited his practice to the treatment of TMJ disorders, headaches, orofacial pain, and sleep apnea. Additionally, he has published a textbook for dental sleep medicine and numerous textbook chapters on orofacial pain and dental sleep medicine. Consumer books, one on the treatment options for sleep apnea and the other of understanding temporomandibular disorders, and various professional and consumer articles. Dr. Patel speaks nationally and internationally on topics of dental sleep medicine and orofacial pain and TMJ disorders. Thank you for joining us as always, Dr. Patel. I'll pass it over to you and we'll go from there.
Trish, thank you very much. I need to shorten that. Honestly, I do need to shorten that. Oh, I'm so
I
sorry.
should have it memorized by the amount of times I've said that. I should have it memorized by now.
It's all good. I appreciate it. Listen, everybody, this is amazing. How many people do we have tonight?
We have 35 on currently.
Perfect. This topic, you guys are going to be amazed with. And I'm saying that only because when I researched this and put this together, and I've been collecting information in regards to this space for probably the last 8 or 9 years. And, you know, we all hear the same lectures over and over again. I'm like, when we lecture and when we get questions, inquiries, this is something that always comes up. You know, what's the connection with sleep breathing disorders or sleep disorder breathing and temporomandibular joint disorders? And we always piecemealed it. We looked at one from one perspective, one from the other perspective. And I always pondered, is there something that ties the two together? And what I want to put on the table is the deal is that what I'm sharing with you is up to the point of September 25th, 2024. And I'm saying that because everything I'm going to state and show you is backed with literature that's up to present. I'll show you some of the, I guess, deficiencies that we have as far as research is concerned and where we maybe need more research, which is why when I get through with this, what you're going to hear is kind of enough information to kind of make you understand where we presently stand on the connection of these two entities. All right, so let's go with that in mind. And like I said, there's a lot more to come. Oh, man. Okay. So this whole presentation is based on literature. All right. So as you notice on the objectives, we're going to do some literature review here. And I want to kind of get you guys up to speed as far as where does the science stand presently? And then we'll dig a little deeper. Now, what I do want to say is this is the dilemma you and I are faced with, right? We have a practice, we have patients that have TMJ disorders that come in, and we have to deal with their signs and symptoms and manage them. But then we may have a practice that have patients that have a sleep disorder breathing, and we deal with their consequences of managing the airway. But is it possible that sometimes they both have both of these entities, and we may be biased based on our training or what we want to see and only treat one and not the other, and therefore negate the fact that there is a co-relationship with both these two entities? So let's just look at sleep disorder breathing. And as we know, there's a lot of signs and symptoms that kind of tie into it. And you guys are very versed in this. And the same thing with TMJ disorder. There's a lot of signs and symptoms that kind of tie into that condition. But there is a common theme with both of them, and that is the process of headaches. Now, the headaches mechanics may be a little bit different, but when I get through with this, maybe we'll understand where some of these headache mechanics are actually coming from. And like I'm saying, I'm going to give you what the evidence points to up to present. And this information, I'm sure, will change in the next 5 to 10 years. Now, let's compare these two side by side just for a minute when we look at the epidemiology associated with sleep disorder breathing and TMD. Well, we know in sleep disorder breathing, males are more prevalent than females, and we know in TMD, females are more prevalent than males, right? We also know that 22% of men and 70% of women suffer with the sleep disorder breathing of some form or fashion. But then when we look at the TMD data, and there again, this varies depending on what work you read and how you interpret this. But if I use clinical symptoms as a reason for experiencing, let me rephrase it. If I'm looking at clinical symptoms, then we're only looking at 6 to 12% of the population. But when we look at clinical signs, that number is much higher. But a sign does not always mean it needs to be treated. It's the symptoms that make patients come in to your practice. Some of the signs that individuals may have, like a clicking, popping joint, but there's no pain associated with it, does not always merit treatment. But pain with a clicking, popping joint, now that there's a symptom associated with it, may warrant treatment. And then if we look at the age bracket, typically middle-aged adults, when you look at sleep disorder breathing, and peak occurrence when it comes to TMD disorders is between the ages of like 20 and 40. All right, so you kind of see that there's some little bit of overlap, but there's still some big far demarcations of both these two entities. So there might be a little bit of crossover somewhere in the middle here. Okay, so risk factors. We know the number one risk factor for sleep disorder breathing is obesity. But if we go down this road, also craniofacial abnormalities will contribute to this condition, okay, along with all those other things listed. Well, let's go to the fact that if obesity is this critical, then we do know that then some data suggests that if someone gets a 10% increase in body weight, then on average, there's a 32% increase in the AHI scores. But conversely, if they lose 10% body weight, then there is a reduction by 26% on the AHI score. So we know there's this bidirectional relation between AHI and weight and vice versa. So what about TMD? You know, what are the risk factors associated with it? Well, there's many, right? There's physical factors, there's psychological factors, there's genetic and biological factors. Let's not forget the psychosocial or psychological factors that might be associated with this, along with occlusal factors, and of course, some other contributing factors. But there might be one thing here that overlaps, and that is the word bruxism or parafunction, whether it be phasic or tonic or however you want to describe this. We're going to use bruxism as a little bit of a landmark to see, can we glue the two together for the short term? But now, do people brux the same every day? Well, this is the thing, right? People think, oh, I grind, so I grind the same every day. Well, it turns out, in this paper by Levy, they looked at 9 patients, and they followed them for about an average of about 9 days. And those that follow through for 9 days, there's data that's on it. Some that fell off for 2 days or 5 days, there's data on it. But what I want to show you is when we look at these 3 demarcations of graphs, the first one on the left is bruxing episodes. You can see there's a variance night by night. Bruxism bursts, once again, you can see there's a variance night by night. And interesting enough, bruxing episodes with noise also had a variance night by night. So you can see there's so much inconsistency when it comes to grinding, right? Funny enough, if we did sleep apnea, if we did AHIs and we measure them using a home sleep testing monitor, for example, you'll find that you also have a night by night variability. It's not the same number every night, right? Same thing with bruxism. It's not the same number of episodes or bursts every night. There's a variability associated with it. So then if we take that for a minute, can we see if there's an association with sleep bruxism and any other sleep-related disorders in adults? And let's look at a systemic review that looked at this. So these researchers looked at a sample size of literature that was about 825 from PubMed, and a total sum, they had about 2,600 papers. They went through their protocols of screening it and discrediting papers that would not meet the criteria, and they kind of whittled it down to 37 papers where they actually used for analyses. Now, I took a snapshot of just a few to show you, but there's 2 papers here that kind of reproduce themselves in a second. So the 2 that I want to bring up to your attention is this one here published by Hosea in 2014, and this one here by Phillips in 1986. All right, so these 2 papers I'm going to bring back for reflection's sake, but I do want to share something. The Phillips paper looked only at about 14 sleep disorder breathing patients and 10 control. And one of the conclusions they drew is the clench index and the AHI are positively correlated, right? So they found that there was a correlation with clenching and apnea-hypopnea scoring, all right? And they did use polysomnogram to analyze that. So it's the most accurate data. If we go to the other paper, they looked at about 67 patients with sleep apnea and 16 control subjects. And once again, when we look at their conclusions here, they say sleep bruxism is sleep bruxism is a sequential event secondary to an arousal event that results from an obstructive apneic event. All right, so let's just come back to these 2 papers in a second. All right, so let's just dig a little deeper here. And then here's the others that they actually used. And if you scrutinize them, most of these papers use polysomnogram. They all had a control group with the exception of a few, but they all kind of drew the same conclusion. So what was the conclusion all these papers drew was this. Sleep arousal may be a common factor with which all the identified, and the word identified is other sleep-related disorders. And the other sleep-related disorders they looked at was sleep bruxism, restless leg, periodic limb movement, sleep-related gastroesophageal reflux, REM behavioral disorder, and sleep-related epilepsy, right? But the common thing with all these other sleep-related disorders was sleep arousal. So just keep that in the back of your head for just a second. So what's the evidence of sleep arousals and sleep bruxism? Well, there's a lot of papers that talk about this. So I won't spend the time, but just to give you a point of reference, there's a lot of papers published correlating the two. So in this group of researchers went one step further. They used a different criteria for doing a systemic review called the PRISMA guideline. A PRISMA guideline is basically a much more sophisticated, robust way of finding papers to be a little bit more, I guess, non-biased to some form. And looking at all the potential papers that will fit the criteria to look at the prevalence of bruxism and obstructive sleep apnea, only 2 papers were eligible for that study. And these are the 2 papers I described a second ago. So what did they find here? All right, so what they found here is the results of the systemic review point to a significant association between bruxism and obstructive sleep apnea. So there again, in 2023, the conclusion is there is some form of association, right? The keywords associated between bruxism and obstructive sleep apnea. Well, then let's look at some of the theories to maybe explain this temporal relationship between sleep bruxism and obstructive sleep apnea. And these researchers conclude stating that sleep bruxism activity may be a protective against obstructive sleep apnea by protruding the mandible and destroying airway patency in those subjects who benefit from a mandibular advancement strategies. Now, remember, bruxism is phasic and tonic, which means in tonic, you are basically clenching. In phasic, there's some form of movement. They stipulating that the fact that maybe sleep bruxism activity is protective in the means of moving the jaw forward to try and offset an obstructive sleep apnea event from occurring. Now, Levy and Cecil's in their textbook, Sleep and Pain, which unfortunately is out of print, but if you get a copy, it's an amazing book to read. They conclude in one of their paragraphs, this statement right here. In the apneic patient, it is believed that the consequent co-activation of jaw opening and jaw clenching muscles, as seen with bruxism, helps to prevent pharyngeal collapse. Once again, drawing to the same conclusion that maybe parafunctional behavior is a protective behavior, not a pathological behavior. But of course, as dentists, we think it's a problem because you destroy teeth and restorations. But physiologically, is it maybe protective of the airway? They also further conclude by saying that, look, because of evidence of bruxism, we should be prompted as clinicians to maybe therefore test for abnormal breathing during sleep. Now, when they use the word abnormal breathing, it's broad, all right? It's not just apnea, but you can also have something called upper air resistance syndrome. You could just have RERES or a combination of various entities related to sleep, all of which may have an arousal reflex, which may therefore contribute to a parafunctional component. Let's dig deeper. So then, is there a relation between sleep bruxism and obstructive sleep apnea based on polysomnogram data? So in this group, they looked at 110 subjects, right? And what they found was something interesting. The prevalence of apnea in this 110 subjects was 86.37%. So almost 8 out of 10, almost 9 out of 10 patients had apnea. However, 5 out of 10, 50% presented with sleep bruxism. And there again, this was determined by polysomnogram, okay? But let's go a little bit further. So they use this thing called the Bruxism Episode Index, BEI, which to our purposes, just call it Bruxism events, it was increased in the group with mild to moderate apnea. So they found a statistical correlation with those with mild to moderate apnea, but not in those with severe apnea. So therefore, anything less than 30 events had a high correlation with having a higher incidence of a Bruxism Episode Index. So they find that there is a relationship of obstructive sleep apnea and bruxism, but this primarily depended on the severity of apnea. They could not explain why they did not see a significant statistical correlation in the severe apneics, all right? So OSA is correlated with sleep bruxism in mild to moderate cases of obstructive sleep apnea in the group that was more increased than those that were severe apneics. So let's go further. So then what's the relationship between obstructive sleep apnea syndrome and sleep bruxism? Once again, a systemic review. Well, these researchers, once again, took 1,700 papers, went through their criteria to meet the question that they're asking, and were only able to isolate 3 papers. What you're going to find here is there's a lot of publications out there, but when you scrutinize the research, valid, good papers, there's only a few, which still means there's a lot of work that still needs to be done. The problem with that is we may draw a conclusion by reading 10 other papers that may not have significant value, but draw conclusions from it. But when we scrutinize those papers to meet specific standards and criteria, we have maybe whittled it down, like in this situation, 3 papers. So what are these 3 papers? Well, here are the 3 papers. So what are these 3 papers saying? So in this one paper here, 67 subjects, all right? So what they did is they took polysomnogram to look at the diagnosis of obstructive sleep apnea and sleep bruxism, so they used PSG, and they had 16, what they call a control group, right? Healthy individuals. What were the outcomes? Well, significant higher risk of sleep bruxism in the obstructive sleep apnea syndrome group. Frequency of these phasic type sleep bruxism correlated positively with that of obstructive events, microarousal, and oxygen desaturation, all which are strongly suggestive of arousals, right? If you look at this paper right here, they looked at 59 subjects. They did not have a control group, but what they found is obstructive sleep apnea and sleep bruxism were concomitantly related in about 50% of these subjects, right? So there's some correlation that they found in half these patients that had apnea that also had bruxism. And in this paper right here, they looked at 10 male subjects. There's no control group, but same thing here. Of the intervals between sleep bruxism and the nearest apneic hypopnea index, there was about 80.5% of the time they found this correlation. So as an apneic event was going to demonstrate on a sleep study, within about a specific time period, there was enough evidence to support that sleep bruxism also occurred. Once again, correlating that there might be some connection with the 2 entities. All right, so let's look into this a little bit more. Is there a relation between obstructive sleep apnea syndrome and sleep bruxism? And the answer here is it can be concluded that there's not enough scientific data to define a clear, now the word here is a clear causal link of obstructive sleep apnea and sleep bruxism presently. Okay. So what is
Dr. Jeff,
yes, ma'am.
it's funny you're saying that because we just got a question that came in and said, wasn't bruxism refuted as related as closely to sleep apnea as we thought? I thought there was a paper somewhere saying that it is simply neurological, not as a result of an apneic event.
So there's a lot of papers that kind of overlap this. And to your point, there's a neurological component, of course. And the neurological component here is the arousal, right? So we know that there's a physical arousal that takes place. What we are trying to say is there's some form of overlap with it associating itself as far as a sleep breathing disorder. And as we go through this, you'll see more and more papers maybe answer these loosened questions. So let's dig a little deeper and see if we can tie into some of these understandings here. So oral appliance, So obstructive apnea events result in oxygen desaturation, which we're all aware of, and there again, an arousal reaction does follow, which often is also followed by a secondary sleep bruxism event, once again correlating the fact that an arousal needs to be present for bruxism to actually occur. Some patients with obstructive sleep apnea did not exhibit sleep bruxism. So here are patients within the study as well finding that they had an apneic event, but they had an arousal, but they did not have a bruxism event associated with it, right? So we still have some research that needs to be done to try and understand the overlap or the correlation between obstructive sleep apnea and sleep bruxism. So therefore, is there an association between sleep bruxism and obstructive sleep apnea? And if we look at it from another perspective, all right, yeah, there are 4 different types of distinctive ways of looking at this. And basically what they concluded here is some subtypes of obstructive sleep apnea patients do have sleep bruxism as a protective response, okay? Most episodes of sleep bruxism occur shortly after the end of an apnea-hypopnea index, which kind of makes sense because you have to have a obstruction take place, you have to have a hypopneic environment to take place, which will then stem an arousal, and the arousal therefore lead to bruxism. Bruxism episodes occur secondary to arousals arising from apnea-hypopnea events. I think we kind of see that correlation here. But there's also there's a correlation between the frequency of sleep bruxism and apnea-hypopnea events. And 3 studies did not support this correlation here. So we can still see that there's some lack of evidence to support this connection or correlation. Right? So the conclusion here boiled down to this: there's not enough scientific evidence to support conclusive relationship between sleep bruxism and obstructive sleep apnea. All right, so let's go a little bit further. Then is sleep bruxism in obstructive sleep apnea only an all health related problem? In other words, is there anything that we should be aware of with it? These group of researchers did a one-night polysomnogram with EMG of the master muscle, and what they did find was the following. OSA patients had a 37.1% prevalence of sleep bruxism, right? So in this situation, 4 out of 10 patients did show some overlap of bruxism events associated with obstructive sleep apnea. Sleep bruxism patients suffer more from a sleep disordered breathing. So once again, our bruxing patients, we should raise the suspicion that potentially an airway component may be possible. But you'll find, if you've done this long enough, some of these tests comes back normal, which is also fine because we still don't understand this direct relationship, okay? But now let's look at it from a Brazilian standpoint. In this research group, they had a series of patients already diagnosed with sleep apnea, and 32 patients were basically worked up. And they worked up these 32 patients that were positively diagnosed with apnea. And what they found was an interesting TMD component symptom associated with it. They found that 52% of these patients had some form of sign or symptom of TMD, of which 75% was chronic pain related to this condition, which means pain that's been lasting for more than 6 months. They concluded that myofascial pain was probably the most common diagnosis that they found in 50% of these patients presenting for an oral appliance to manage the obstructive sleep apnea. Okay, so if half these patients that already been diagnosed with apnea present with myofascial pain, what therefore would drive myofascial pain? And we do know that parafunction is one of the underlying issues that will give you myogenic pain. So can it be that some of this myogenic pain that's being presented is due to the fact that maybe bruxism is a little bit more prevalent in these apneic patient population? As you can see, if bruxism was associated with the vast majority, then those numbers would be much higher. So the prevalence of signs and symptoms of TMD disorders in patients with sleep apnea. What does this data support? Well, of the 41 patients that these researchers looked at, 51% present with signs and symptoms of TMD. All right, so these are patients, once again, presenting to a clinic, and they find that almost half of these patients that have sleep apnea have some form of a TMD complaint. So the prevalence of TMD signs and symptoms is significantly higher, of course, in the untreated patients with obstructive sleep apnea. Now, what are they thinking that might be connected with this? Well, maybe sleep deprivation and disturbance in sleep structure are associated to what we think is musculoskeletal pain, which leads to tenderness and fatigue, not only affecting other body sites, but also the mastoid muscles. And we're going to see this literature kind of thought process towards the end here. But there was a bias with this paper. And the problem was the control subjects was only based on questionnaires, not using polysomnogram, whether they did or did not have apnea. So there was a little bit of a biasism on this paper. But this conclusion they drew, you'll find that it replicates itself in other papers as well. So then, is it an association of sleep and pain? So we do know that pain may influence sleep, but we also know that sleep may influence pain. So let's see where this takes us. So in this scenario, sleep impairment was a strong and a more reliable predictor of pain than pain is of sleep impairment, which means that if you are in chronic pain, pain per se may not completely disrupt your sleep. But sleep interruptions that you may have, maybe it's apnea, hypopnea, PLM, restless leg, whatever you might have that might be contributory, will influence the effect of pain. And what they think maybe the reason for that is that the sleep disturbances may impair some of the processes involved in the which lead to the development of chronic pain by reducing the pain inhibition system or the endogenous pain system that helps modulate pain. So they think that the lack of quality sleep or the lack of continuous sleep affects the pain modulating system that therefore affects pain, right? Let's look at this from another perspective. Is there association therefore with TMD disorders and sleep apnea? So in this study, they looked at about 1 million database records, since it's a national database, and basically whittling it down to patients with possible sleep apnea versus control subjects. So they had about 4,100 subjects that had sleep apnea and a control group of about 4,150. Okay, so they kind of used two arms here to compare. So what they concluded was this, that what it relieved that patients with sleep apnea had an independent risk factor for the development of TMD, or what they call a hazard ratio of 2.5 times likely, okay, in the group that had a sleep apnea as opposed to the control group. Well, we will find other papers basically drawing very similar conclusions right here. So if you look at this paper out of Korea, primary sleep disorder patients had a 44% higher risk for TMD compared to non-sleep disordered participants. Okay, once again, correlating that patients with apnea may have a higher prevalence of a TMD disorder. Okay, so primary sleep disorders could be an important independent risk factor for the initiation, and in some cases, the maintenance of TMD. Therefore, patients with sleep disorders should be monitored for possible co-occurrence of a TMD-related symptom that could aggravate the sleep disorder in turn. If you look at Smith's group, and this paper is an older paper, but it stands really true, and there's some good conclusions I want to pull from the table of data. So what they found is that a series of 53 patients presenting to a clinic that had signs and symptoms associated with the TMD disorder. And what Smith and their group decided to do is not treat them, but put them all in a sleep lab. And doing polysomnogram, they looked at the data from it. And what they found was, in the population that had a TMD symptom, almost 28% of them had some form of a sleep apnea diagnosis. So almost 1/4 of these patients had a sleep apnea diagnosis of some sort. But the interesting thing was this. So self-reported bruxism was about 73%. However, polysomnogram-derived data show that only 17% of them bruxed at night. Okay, so that's an interesting observation. And this is so true in many other papers that talks about incidents of reported bruxism, which is by questionnaire versus polysomnogram. There's a huge discrepancy between the two. And if you look at any other sleep disorder that these patients had, and that could be primary insomnia, that could be insomnia due to either mood disorder or a TMD problem or any of these components, then 88% of these patients that present with a TMD disorder had other sleep disorders that need to be addressed. So let's jog a little bit more, and let's look at some PSG studies that were done in women looking at respiratory parameters, all right? And what did they find in these patients that had TMD? Well, the first observation was interesting. A lot of these patients with TMD had a larger time in stage 1 sleep, okay? Which means the stage of sleep that you're not really in excessively, they spent a lot of time there, which is almost equivalent to awakening. And this typically will happen due to stage shifting. So as you sleep, if there's an event that occurs, you'll stage shift. And when you look at the data, a vast majority of these patients were stuck in stage 1 sleep. Okay, so they basically had poor sleep. If you look at the respiratory arousal index, they had a higher respiratory arousal index as compared to the control subjects. And if you look at respiratory effort related arousals, they also had a higher percentage of these conditions in women with TMD disorders. Okay, when you look at respiratory parameters. And as you know, women have a higher incidence of TMD as outlined in the epidemiological data. So can it be that a lot of this might be contributory from a sleep perspective? All right, let's look at it from another perspective. So when you look at this Mendelian randomization, they look at the causation relationship between obstructive sleep apnea and temporal memory disorders. And is there a bidirectional relationship? And the conclusions are pretty straightforward here. So looking at this data set, they found that OSA has a causal effect on TMD, very similar to the other papers, right? But not on TMD on OSA. All right, so therefore, obstructive sleep apnea can lead to someone having temporal memory joint disorders. However, a TMD disorder does not lead to them having obstructive sleep apnea. All right, so therefore, effective intervention should be implemented to prevent and relieve any TMD symptoms. What about sleep apnea symptoms and the risk of TMD in the OPERA cohort study? And if you look at their conclusions, very parallel with the previous ones. OSA was associated with a greater incidence of first onset TMD with a hazard ratio of 1.73. Okay, and when you look at the case control study, there's a high likelihood of OSA was associated with the higher odds of having chronic TMD with the odds ratio of about 3.63, strongly supporting the fact that a sleep breathing disorder may contribute more to a TMD component over time. Other causal associations between sleep traits and temporal memory disorders to see it from another bidirectional relationship. And what these researchers looked at is basically genomic data of about 400,000 European participants. And what they whittled this down to is the fact that this study for the first time examined the causal relationship between 5 sleep traits and TMD, empowering Mendelian randomization analysis. And what they found was that findings suggest that getting up in the morning is protective against TMD. whereas insomnia constitute a risk factor. And when they use the word morning, getting up in the morning is protected, basically sleeping adequate amount of time at night and waking up in the morning does not really lead to a TMD problem. However, those that are insomniacs or have broken or fragmented sleep seem to constitute a higher risk for it, right? No causal association was found between sleep duration, snoring, daytime napping, and TMD. However, likewise, experiencing TMD does not influence the sleep traits. So if you have a TMD disorder, it's not going to affect how long you sleep. It's not going to affect your snoring, whether it contributes to daytime napping and things of that sort, right? So individuals with chronic insomnia and frequent late awakenings, meaning that fragmented sleep, in this case, they're looking at how long they slept for, so oversleeping, should prompt the evaluation of TMD. All right, so potential role of obstructive sleep apnea on pain sensitization and jaw function in TMD. So knowing that OSA can contribute to TMD, what is therefore the effect on pain sensitization of obstructive sleep apnea? So in this series here, they looked at myofascial trigger points. And what they found was in the obstructive apnea group, there was a high incidence of finding mastoid muscle trigger points, all right? We found that there was a high incidence of hypopneas, along with the fact there was a high incidence in control subjects of respiratory disturbance index. There was a high incidence of respiratory arousals, and of course, hypoxia being another component. What they drew the conclusion is that significant high numbers of active trigger points were detectable in participants with severe obstructive sleep apnea, therefore supporting one of those early papers suggesting that when apneas came into the clinic, more than half of them present with myofascial diagnosis, about 50% of the patients, and they're again looking at this data set, kind of pointing in the right direction. So it supports the fact that myofascial pain, modulating mechanism, and jaw function could have interactions with nocturnal hypoxia and sleep fragmentation in chronic pain-related TMD patients. And if you look at this for a minute, the key here is interaction with nocturnal hypoxia and sleep fragmentations. What you know thus far is there's a high incidence of arousals with people with sleep, with hypoxia, as well as those with sleep fragmentation, right? Both of them very contribute to the fact of fragmented sleep that can, in this instance here, present with a high incidence of myofascial pain. So then let's look at the association with mandibular retrognathia and TMJ disorders. Is there a connection with anatomical features and TMD? Well, we do know that there's some strong association with mandibular retrognathia, specifically in females, and a high incidence of TMD. And if we look at it from another perspective here, we know that a hyperdivergent facial profile, more lingual tipping of the maxillary teeth incisors, and a steep inclined occlusal plane may be more contributory to a TMD disorder. Well, we also know, therefore, then, when it comes to obstructive sleep apnea, there's also an overlap here, retrognathism and so forth, that can also contribute to high incidence of having obstructive sleep apnea. So craniofacially, there may be some overlap here as far as jaw relationship, where both of them may have significant risks associated with whether it's a TMD disorder or sleep breathing disorder. This was interesting, right? The relation between sleep bruxism and obstructive sleep apnea based on polysomnogram findings. So when you look at this data set, there were some interesting conclusions drawn here. Because they took a lot of other health-related metrics, statistically, they found this. There's a positive correlation with not just apnea-hypopnea index, but also with bruxing episode indexes, was observed in the group with an AHI less than 30. Regression analysis indicated a higher AHI, male gender, and diabetes were independent predictors for the increased bruxism episode in the group with an AHI less than 30, right? And the funny thing here is diabetes statistically correlated with it. Well, here's the interesting part too. We know sleep apnea and type 2 diabetes have some form of overlap, right? We also know that there's a lot of papers that kind of show this overlap between type 2 diabetics and apnea. I want to just expound on this a little bit more. So diabetes may be a new potential risk factor for bruxism, as therefore there's some data to support this sort of association. Diabetes is also associated with cardiovascular neuropathy, which therefore results in a decrease in parasympathetic tone and sympathetic overactivity because the parasympathetics are being suppressed, similar to what happens when you have an arousal and you have sympathetic activation associated with bruxism. Bruxism is considered as a protective factor, right, in impaired salivation. We know that from the other studies, when they look at pH, esophageal pH, you'll find there's a high incidence of bruxism, and the theory there is the fact that you produce more saliva to dilute the acids. So therefore, decreased salivary flow also occurs in diabetics. Thus, these findings may explain the increased risk for sleep bruxism in diabetics. Now, I dug into this as much as I could. There's not that many papers, but I think you might see more stuff come out in associated with this. So just something to ponder on, something to keep in the back of your mind, the association of diabetes and not just the apnea portion, but a high incidence of possibly bruxism in that patient population. What's the investigational relation between sleep disorders and xerostomia? Right, let's just look at that for just a second. So these researchers look at Epworth Sleepiness Scale, they looked at the Perspex Sleep Quality Index, the Berlin Questionnaire, and so forth, and they kind of drew an interesting conclusion. Subjective feeling of dry mouth is related to excessive daytime sleepiness, poor sleep quality, and high risk of obstructive sleep apnea and sleep bruxism. But larger scale studies are still needed. This was a small sample set, but the point being that there might be some overlap here. Well, then let's go a little bit more and look at inflammatory cytokines. I mean, we know that inflammation needs to be a component here, and therefore these cytokines may play a role. So if you look at cytokines associated with temporomandibular joint disorders, we know there are a couple of big players there. We got the interleukin-1 beta, the IL-6, IL-10, and TNF-alpha, right? And we know that there's been an increased association with Epworth Sleepiness Scale and the Perspex Sleep Quality Index, and which is strongly suggestive of sleep disturbances. But you also will find that there's other comorbidities that might be associated with this, and that's anxiety and sleep disturbances in patients with temporomandibular disorders. So could there be an overlap here? And if we look at some of the papers associated with inflammatory markers, there's a lot that talk about synovial inflammatory markers along with temporomandibular joint disorders and so forth. But I don't want to labor this point. I just want you to be aware that there's an inflammatory pathway that might be playing a role here. So we know sleep can play a role when it comes to inflammation, and we know pain plays a role when it comes to inflammation. Can it also be the fact that maybe there's this bidirectional relationship between the two, and the denominator being cytokines, right? Like such as TNF-alpha, maybe playing a role here, which may affect both these two entities. So if you look at some of the literature from the rheumatological data, you'll find some interesting findings. So one of the biggest complaints with sleep patients is fatigue. But with some of the big findings that you have with TMD patients is also fatigue. But let's look at this diagram right here. Fatigue, pain, psychological disturbances. But if you look at the common denominator with all three right here, we have inflammatory cytokines that may play a role here, right? Interleukin-1, 6, TNF, and interleukin-8. And if you look at what they are concluding is that fatigue could be associated with activity of inflammatory, in this case, rheumatism. Indeed, biological agents targeting inflammatory cytokines are effective in fatigue. I'm not sure if you have had these similar experiences when you have patients on anti-inflammatories. Sometimes you'll get one of the biggest feedbacks is, I feel more rested. I don't feel exhausted. But I gave you an anti-inflammatory. I didn't give you a sleep aid. So once again, is there may be some form of a connection or correlation with interleukin factors as well as fatigue being a component here. And interesting enough, inflammation could be the common link between fatigue, pain, and depression. So we want to be mindful here because in chronic pain patients, you have fatigue, you have pain, and you have depression. But in apneics, you have fatigue, right? You also have depression, and of course, all the other aspects associated with a sleep breathing disorder. So let's look at fatigue and chronic pain from another perspective here. So fatigue is clinically relevant symptom, right? It's distinctive from depression. It definitely shows poor sleep quality or pain intensity and may be related to worse pain outcomes over the following months in adults with chronic temporomandibular joint, whether it be arthralgia or myalgia. But if you go to the opposite side here, you'll find that there's some reports that between fatigue and circulating levels of inflammatory markers in population of pain suffering from the diseases, therefore may be suggesting that there may be some multidimensional perspective due to inflammation and pain and fatigue. So if we just take a sidewind and we look at hormonal aspects, we do know that estrogen plays a role when it comes to pain, which is why there's a high incidence in pain in females, right, when it comes to a TMD disorder. But we know there's some subtypes. The polymorphism of estrogen receptors may increase the risk of women developing a TMD disorder. And we do know that there are other papers to show very similar findings and correlations when it comes to estrogen levels and pain modulation. But if we go to the opposite side, we also know that in obstructive sleep apnea patients, there seems to be an association with estrogen being protective. And of course, when they go into perimenopause, menopause, now the risk of apnea almost equals that of men. So we know that estrogen may play a protective role when it comes to airway-related issues here. All right, let's look at vitamin D. Let's just see, is there anything on vitamin D here? So with vitamin D, patients with TMD disorders have an increased parathyroid hormone level in response to vitamin D deficiency, and which was very significantly demonstrated in several papers, right? Vitamin D deficiency are more common in women and associated with poor musculoskeletal health and higher cardiovascular metabolic risk. We know that one of the symptoms of myalgia, when everything has been rolled out, is to look at vitamin D levels, because low vitamin D levels will give you myogenic-like symptoms. But this was also interesting, is when you look at apneic patients, they also found some data to support that there was a lack of vitamin D. However, one of the interesting conclusions was the fact that apneics being overweight are very sedentary and may not be as active. And could it be the lack of exposure to sunlight is the reason why there's a vitamin D deficiency? There's a lot of papers looking at it from different perspectives, but no specific conclusion. But the one that kind of repeated itself was from the Mayoor standpoint of the fact of lack of activity and therefore decreased levels of vitamin D. Sleep quality in TMD disorder patients, right? What do we know about sleep quality? So when we look at sleep quality, here's TMD cases with 1 to 5 TMD diagnoses were looked at. What they concluded is that sleep quality is impaired in patients with TMD, with pain-related diagnosis being the most common reason for it, all right? The effects of sleep deprivation on pain. Is there sleep deprivation and pain? Is there any correlation with the two here? All right, so when you look at this data set, sleep quality, sleep continuity, now the key word is continuity disturbances, but not simply sleep restriction, impairs the endogenous pain inhibitory function, once again leading to some of the papers that we talked about earlier. An increase in spontaneous pain, supporting the possible pathophysiological role of sleep disturbances in chronic pain. What I want to make clear here, it's sleep disturbances, not sleep restriction. So in this research, they restricted people from sleeping for a certain period of time, and they didn't get the same effect. But when they disrupted their sleep, very similar to what an arousal does when you're sleeping, when you disrupt one's sleep and you fragment it, they found that there's a higher prevalence of pain in that patient population. The effect of sleep restriction, right, and they looked at it from another perspective and came to the similar conclusions here that sleep restriction induced the CNS response to pain. So once again, restricting sleep. Now, sleep differences as you measure to central sensitization, is there anything that we can kind of look at that from a sex perspective? And what these researchers actually concluded is that so these guys kind of came down to the conclusion that secondary hyperalgesia in males and significant increased temporal summation in females was observed when you actually looked at it from a sleep sensitization standpoint. All right. Digging a little deeper, they also found that significant reduced heat pain threshold and cold pressure pain tolerance was independent of whether it's male or females. All right. The effect of sleep deprivation on pain. All right. Evidence that the deprivation of or the disturbance of sleep enhances pain sensitivity and causes pain was also looked at. And pain disrupts sleep by inducing arousal and triggering all other neurological sequences of stress that are incompatible with undisturbed sleep. Hence, therefore, they think that an ongoing sleep cycle might arise starting earlier with disturbed sleep or with pain in which the two components stabilize or even augment each other. So according to this, sufficient management of disturbed sleep might alleviate pain. And what you'll find here is when you control pain in some of your patients, sleep does improve. But vice versa, you can control pain in some of your patients, but if an underlying sleep issue is still present and there's not restorative sleep, there's not much of a dent that you'll find when it comes to pain outcomes. And there's many papers I've actually looked at this, and I've listed a few for you to kind of read back on, but the conclusions were very similar here. So if we look at this from another standpoint, what some of the mechanisms that kind of maybe contribute to this? Well, we know central sensitization and pain amplification in decreasing function in pain inhibitory systems, for example, via the baroreceptor receptors may play a significant role. Well, how do the baroreceptors come into play? Well, experimentally, when you're causing inspiratory resistance, it reduces the baroreceptor reflex, which therefore sensitizes in humans and impairs baroreceptor reflex, which therefore the reflex which sensitizes is implicated in TMD symptoms. All right. Let's look at it from another perspective. Increased stimulation of the sympathetic nervous system, when it boils down to, as observed in obstructive sleep apnea, which an arousal will lead to a sympathetic activation, underlies an increase in prevalence of TMD. All right. Paroxysm, which is more common in people with obstructive sleep apnea than those with obstructive sleep apnea by itself, may be implicated in TMD development. And the underlying issue here is the arousal response. So the arousal response leading to a parafunctional component, which therefore leads to the temporomandibular component associated with it. We know that there might be a bidirectional association between esophageal sleep apnea and TMD, and this has been suggested when you look at some of the incidence and prevalence of TMD in OSA patients, as outlined earlier. We do know there's an increased prevalence of obstructive sleep apnea in TMD patients, but we also know that TMD itself does not contribute to OSA. It's OSA contributing to TMD. Women with TMD present with more respiratory effort-related arousals and then healthy controls, predisposing them to the development of obstructive sleep apnea. And that's an interesting observation. That's the only paper that kind of showed that. But what they were referring to is a high instance of rares, which therefore would contribute to upper airway resistance syndrome, contributing to those findings. So,
Dr. Patel?
Yes, ma'am.
Dr. Ely has a question. She said, I understand that women in childbearing years are more prone to having TMD disorders because of their higher estrogen levels. Since we see that sleep apnea incidence increases with menopause when estrogen decreases, would that mean that menopausal women are less likely to have TMD disorders?
Yes, so according to that data set, that will be true. But here's the twist off, and you'll see this quite clinically. Yes, the high incidence is peak incidences when they are in the menses, right? So teens that are starting to menses, you'll see there's a high incidence of pain. But as they go into latter life, you see that pain actually decreases. But what unfortunately does show up is arthritis. And not to say that there's a correlation with estrogen and arthritis, but the parafunction and all the predisposed TMD issues that may be present may lead to an arthritic event later in life. And what they're dealing with at that point is more arthritic pain than myogenic pain. All right. What's the occurrence of TMD disorders among patients undergoing treatment of obstructive sleep apnea? So let's look at it from another perspective. So these researchers whittled down 497 papers, met the criteria for the PRISMA guidelines, came down to 13 papers. These are the papers that they actually cited. I won't labor the point here, but I just want to draw some of the conclusions that they came up with. And what they found was different outcomes associated with TMD are affected differently by mandibular advancement treatment of obstructive sleep apnea syndrome, right? So therefore, when you're managing these patients, the outcomes of TMD were different. According to a few studies, MAD therapy significantly reduced the severity and frequency of TMD symptoms. And that's so true. You'll find that a lot of times when you have an airway patient and a TMD patient, and you decide to treat the airway, the TMD symptoms actually improve. Okay, but if you also think about the logistics here for a minute, if I had a TMD patient, I was managing them, I'd maybe, depending what your philosophy might be, position the jaw in such a manner where there's a little bit of an anterior repositioning done or a stabilization done to some form. And as a result, TMD improves. Well, that might not be any different than when you use an oral appliance to manage obstructive sleep apnea. But they also found that in some cases, there was not much indication for one over the other. So more research needed to be done. We also know in some instances, if a person has an underlying TMD issue and you manage the obstructive sleep apnea, you can actually worsen the situation. So we got to be mindful as far as that is concerned as well. What about this situation right here? Evaluation of mandibular advancement devices when it comes to TNF alpha. And this is interesting as well. There was a statistically significant decline in the level of TNF alpha within 3 to 6 months while managing obstructive sleep apnea. All right, so using a mandibular advancement device. This does correlate to the fact that we do know that inflammation may be a factor when it comes to orofacial pain, but if you have an underlying sleep issue, management of the underlying sleep issue may be indirectly contributed to the reduction of these inflammatory markers, such as TNF alpha, and therefore may be contributing to a better outcome when it comes to the orofacial pain component. However, their paper showed it took 3 to 6 months for that reduction to occur. So it didn't happen overnight, didn't happen within a few weeks. It took a little bit of time for that to occur. So what I want to do now is, seeing what you just saw a minute ago, I just want to tie in some things that we see clinically every day. Most of your patients will present with a muscular component, or they're going to have a temporal memory joint component, right? So these are your two major categories. You're going to have an extracapsular or an intracapsular problem that they're going to present with. And we know that one of the biggest issues when we manage these patients is a bite change that occurs at night using a mandibular advancement device. And I think you all know the reason for that bite change is the fact that the lateral pterygoid muscle is contracting at night. And as a response, the next morning, it's still somewhat contracted, and it requires you to do those morning activities, exercises, and whatever you prescribe to your patients to kind of release the pterygoid so that the condyle sits back and the bite returns, right? But then you also have this situation right here where the person at delivery had a decent occlusion, but maybe it was not determined that they had an anterior disc displacement that was chronic. So the range of motion numbers look good. All the factors that you did not demonstrate that they had a chronically displaced disc. You fit them with the device, and now when you put a device in, there's two things that happen. There is the condyle that comes down and forward in the fossa, but by doing so, it opens up that joint space, as you can see compared to this cartoon illustration on the left. So if the joint space is open, there can come a time where now they have a bite change that is more unilateral in nature. And the reason for that unilateral bite change is the fact that maybe now the disc has reduced. So because now it's occupying space, you're going to have that change in bite. So be mindful that when you see a unilateral bite change, you need to think of probably an internal derangement that they may have had potentially that now has reduced that you missed up front, okay? Myalgia is another thing that you may present with these patients that you're managing with oral appliances. So what's the deal with them? Well, you need a couple of things to diagnose myalgia. You need regional dull aching pain, right? That's typically affected in muscles of function. There's normally no pain at rest, but there's pain in function. Local muscle tenderness, which means you can reproduce the pain if you palpate. And with myalgia, there's no trigger points. In other words, if I push, pain stays where I push. It's not being radiated elsewhere. But the following may accompany with these patients may present with some sensation of muscle stiffness, weakness, or they may say, my muscles feel tired or fatigued. Mouth opening may be reduced, but that might be more to mouth guarding, not really an internal derangement. And the way you can differentiate the two is just put your fingers in the mouth and see if you can pry them open more. If you can, we call that soft end feel, and you're dealing with the myogenic component here. But there again, you might have some of these patients may present with joint pain. So what do we need with joint pain? Well, with joint pain, we need a diagnosis. Most common diagnosis will be either capsulitis or synovitis. The problem with that is very hard to differentiate the two. So we clump it together. We just call it capsulitis. And typically that's inflammation of the synovial lining. There's pain that's localized in the general area of the joint, but it gets worse with function. And occasionally you may have swelling in the joint, and depending on the type of swelling you have in the joint, they may have a unilateral light occlusion on the affected side, on the ipsilateral side. You will, in some cases, have tooth pain or teeth pain that happens on awakening. These can mean significant aggressive bruxers. And as you now know, you can manage the airway, but that does not always mean bruxing is associated with airway-related events. We do know that bruxing is related to arousals, but arousals can come in many different forms. Medications such as SSRIs, SNRIs, in some instances, for some patients, may cause arousals. Periodic limb movement can cause arousals and so forth. So these are things that can still drive the parafunctional component. But these are patients that may waken up with pain, but typically that pain only lasts for about 30 minutes when it comes to teeth and dissipates. A couple other things that you can have pain. If at delivery there's pain associated with teeth, it may be wear on a stone or maybe a distorted impression. The solution is just adjust the area. But if you have multiple teeth that are hurting, then you just want to get a new appliance made, right? When you scan, you don't see this as often, but you might see this more when you're taking impressions of teeth. Clenching, as I talked to, if you have clenching, depending on the type of device you have, if there's posterior contact, then add an anterior discluding element, take the pressure off the back and see if that helps. If you have a device where there's no posterior component, but they have a lot of pain on the anterior, maybe give them some posterior support. A classic example of a device as such will be your tap type devices. Maybe add some acrylic on the most posterior, give them that support, and you might see that that pain in the anterior does lessen. All right, so these are a few things that you want to keep in the back of your mind. You do run into this on occasion when you have open contacts, more in the second molars, sometimes the first molars. The most common reason for that is not the fact that you didn't wrap the most posterior tooth, but typically if they have embrasures, the device is made with those embrasures, and then they parafunction on that device. It's like a wedge-like effect. And as a response, you may have open contacts that develops. So in that case, just tell your lab, block out the occlusal embrasures. Always keep the buccal lingual embrasures so you have better retention. What I want to show you here is just to sum up a flow, because these patients, as I alluded to in the beginning, may come in for sleep, may come in for pain, but hey, maybe they have both. So how do I know what I'm dealing with? And sometimes you don't know until you go through this pathway. And I make mistakes every day where I have to rethink my diagnosis. So there's no perfect way of identifying them. You can have the stop band, you can have the Apple questionnaire, you can have all the key data that you need. But the question here is, what is feeding what? So let's just look at this example here. You have a patient that presents themselves and you suspect they have a sleep breathing disorder, but they also have a TMD component, right? So they came in with pain, but you suspect they have a sleep breathing disorder. You go through your suspicion list, you go, nah, I don't think you have an underlying sleep issue. Let's go down the pathway of treating your pain. If treatment works and you did great, then continue with treatment, you're good to go. But what happens if you start treatment and they're not getting better? So what you know up to this point, there are other factors that need to be taken into consideration, such as sleep quality, sleep apnea, sleep fragmentation, all the things I kind of alluded to. Could it be contributing to this pain? This is where I need to reconsider my diagnosis and maybe refer them to get a diagnosis made to see, is there or is there not underlying sleep disorder breathing? If there is, then let's go further with it. If there isn't, let's continue with pain. Let's carry on managing it. But if there is, let's manage their symptoms first, but also take into consideration the management of the underlying sleep issue, or you're not going to get positive outcomes. All right. Now, the problem is we go ahead and maybe manage a lot of TMD patients with splints, occlusal splints. This is basically bread and butter for most dentists when it comes to some form of TMD discomfort. But I want you to understand that an AHI may increase purely on the fact of sticking something in someone's mouth, right? So we need to be mindful that we need to take into consideration that if they have an underlying sleep issue that needs to be also addressed, or if they have high suspicion of having an underlying sleep-related issue, that may need to be taken into consideration first before sticking with an appliance, right? And you'll see that there's papers after papers kind of showing you the same thing, that when you put a splint in someone's mouth that may have apnea, you can actually, in some cases, make it worse. All right, so I want you to be mindful when it comes to how you prescribe your therapy, but also be respectful for the fact that you need to take a look at this. I do want to share this, though, with you. This is an interesting paper, and there's a couple of others that show very similar outcomes. So in this group of patients, they had bruxism, right? So what they did is they put them in mandibular advancement devices. And what they found is when they protruded the devices, there's a significant reduction in the number of bruxing episodes. So when they took the mandible 25% forward, there's a 39% reduction in parafunction. And if they took the mandible 75% forward, there's a 47% reduction in parafunction. So there again, maybe supporting the fact that in some patients, some of the parafunctional activity may be directly related to an airway arousal to some form of fashion, because we know that mandibular advancement devices opens up the airway, and therefore by opening up the airway, if there's a reduction in parafunction, then some of it may be an overlap or correlate with it. What I'm hoping you see here, it's not 100% improvement, all right? Which means there's other reasons why people brux. It's not just airway related, okay? Effect of raising the bite without mandibular protrusion, obstructive sleep apnea. So if you're an apneic patient, the only thing you do is you give them vertical, but you didn't take the jaw forward, you'll find that you'll aggravate the AHI. Right? So once again, when you're dealing with apneic patients, it's not just about vertical, but it's also about protrusion here. Okay, I mean, I could go on. I get on. You've got these. I don't want to labor the point. I know I'm past my time, but what I do want to shed here is the fact that there's a lot of science up to this point supporting the fact that we still, to this day, don't know the answer to this question. However, there's enough observations to at least strongly support that there is some overlap between sleep breathing disorders and TMD, and the common theme might be two variables. One is sleep disruption, which is the fragmentation of sleep, and the other being arousal, which therefore can be contributed to sleep bruxism and so forth. So keep in mind that as far as where we stand, more work needs to be done. But when we have apneic patients, we need to explore the fact that they may have an underlying TMD disorder. All right, so keep that in the back of your mind. And when we have a TMD disorder, it's not going to cause them to have apnea, but apnea may be an underlying issue that's contributed to the TMD disorder. So with that, I'm going to pass this back to you, Tricia, and we'll go from there.
Excellent. All right. Well, thank you everyone for joining us this evening. Feel free to keep those questions coming. We will address those here in just a moment. So keep those coming in the question box. Again, thank you for spending your evening with us. And as a thank you, we'd like to offer a $200 off coupon towards Dr. Patel's Level Up DSM course. It's going to be 2 weeks from Friday, October 11th. So you can use code TF200 to receive $200 off that one-day virtual course on October 11th. Can you go to the next slide for me? We have some really great, exciting webinars coming up. The next webinar is going to be on November 13th. It's featuring Dr. Bradley Rowan and Dr. Anju Ely regarding bridging the medicine and dentistry gap for better sleep. We also have one coming up December 11th discussing medical billing for sleep and TMD. So you can register for those by scanning that QR code on the screen or going to our education tab of truefunction.com. There on the education tab, you'll find all of our webinars coming up as well as the link for Dr. Patel's Level Up course. So feel free to join us for that. If we can help you with any of your needs for appliances, feel free to go to the main page on truefunction.com and click on that Get Started button, and we can get you set up an account, and we can assist you with those appliances. So again, keep any of those questions coming in the question box. Thank you again for spending your evening with us, and we look forward to seeing you at the next webinar. And thank you so much, Dr. Patel. We always love when you can join us here.
Thank you, thank you, thank you.
Did you, I did send you a chat, if you could take a peek at that for me.
Sorry.
Okay. We will be sending the recording of the webinar out as well. So everyone will be receiving the recording of that probably early next week. So keep an eye in your email for that, and it'll be the full recording of the webinar. Dr. Patel will also include the PowerPoint in that recording. So for those of you that are asking for the PowerPoint and the slides, we'll add that into the recording. So keep an eye out for that email. Like I said, early next week, we got to do a few edits to it, and it'll be ready to go then.
Oh, Alberto. Oh my God. I miss my friend Alberto in Peru.
Yeah.
My daughter was saying that she wants to do study abroad in Peru. I said, I know some people there. So let's see what happens.
Yeah, Dr. Diaz, he joins us pretty frequently. It's good to see
Oh,
you.
Barry Glassman. Oh my God. Thank you very much, sir. You can call me later and please give me your critics. I would really like to learn from you. As you know, I am so indebted to your knowledge, and I'm glad you're on this webinar. I did not realize that.
There's so many wonderful familiar faces. All right, everyone. Well, if no one else has any questions, I think we'll wrap it up here. That we work with to become more educated by you. Oh, thank you, Dr. Kane. I don't know if you saw that, Dr. Patel. Dr. Kane said, I own a sleep disorder center, and I would love to help refer some of the dentists that we work with to become more educated by you. That was great. Dr. Patel is doing a Tufts residency coming up. So if they're looking for more education, that's always a great 4-session course starting.
It already started last 2 weeks ago.
Oh, it did, the virtual session. Oh, sorry.
If they want to jump in session 2, 3, 4, session 1 was recorded because we had to do it by Zoom since Tufts was closed for repairs. I'm sure the university will give you access to the entire first set of lectures we did, but sessions 2, 3, and 4 will be in Boston. If you want more information, you got 2 ways to find it. One, go to Tufts, I guess the education page, or you can go to BenPat Institute, and there's a link from there to the Tufts page if you want more information regarding it.
And Dr. Kane, you should have probably been receiving my emails as well. If you email me, I can send it to you too if you can't find it. So. Excellent. All right. Well, thank you, everyone. Have a wonderful evening. Thank you for joining us, Dr. Patel. We really appreciate you. And hopefully we'll see you again for Dr. Ely's webinar in November. And have a great evening.
Thank you, guys. All of you have a good evening. Thank you, Trish, for everything.
Thank you. Yeah, you as well. Take care.
Bye, dear.
Bye.